This slide's presentation covers the medical and physical therapy management of patients with multiple sclerosis. In general, I'm going to talk about 4 categories of management. The first part will be treatment of acute exacerbations or relapses in this patient population. The second will be the use of disease-modifying therapeutic drugs, followed by physical therapy rehabilitation and symptom management. As far as acute relapse management, you should know that the natural improvement that occurs after a relapse usually takes about 4 to 12 weeks on average. And now remember, this is going to vary depending on what kind of multiple sclerosis the person presents with. If they have relapsing remitting, this applies. If they have a progressive, whether it's primary or secondary progressive, you're not going to notice any improvement. Okay, you should also know that the degree of improvement varies. Even if a person has relapsing remitting multiple sclerosis, they may have a relapse or exacerbation and then come back down to their baseline, or they may never quite make it back down to their baseline. Okay, it's just going to depend on the person and the amount of demyelination present. Treatment here is a medical management, and it's going to involve IV or oral corticosteroids. Okay, the corticosteroids are designed to help reduce the inflammation and end the acute attack sooner with fewer permanent lesions resulting. Next, medical management can also use disease-modifying therapeutic agents. Okay, these work only in the early stages of multiple sclerosis. They are not effective at all in the later stages. The goal is to reduce the frequency of the relapses, help with progression of the disability, and reduce the number and volume of CNS lesions. They actually work by reducing immune dysfunction, and this in turn reduces the CNS damage. As I mentioned, they are not effective in late stages, mainly because they target an inflammatory response, and as we talked about in previous slides presentation, there is no inflammatory response. It's more of a neurodegeneration in the later stages of multiple sclerosis. The mode of delivery for these drugs is injection, oral, or IV infusion. The most important thing to know about these drugs is they contain some very serious side effects. Okay, I've put a link into the O'Sullivan table that lists these drugs. I think probably the most important thing to be aware of is the fact that some of the drugs have side effects of depression and suicide. So as far as physical therapy treatment is concerned, you should have a good general knowledge pertaining to medication side effects. Okay, if you're working with a person with MS, take the time to look to see what kind of medication they're on and if there are any substantial side effects that are going to affect them. If you note any occurrence of depression, it might be a good idea to refer them to a healthcare professional to help prevent any future suicide. As a therapist, you're going to coordinate your treatment with the medication schedules, and you want to note any changes in the patient's performance over time. And as I've mentioned, there's actually a natural improvement in this patient population after a relapse. So it's difficult to tell if this improvement that you're seeing is just the natural course of the disease process, or if what you're actually doing in therapy is helping, or if their medication is helping. So make sure that you're carefully documenting everything that you're doing and all the changes that you're seeing. Physical therapy is going to consist of a comprehensive neuro exam. One of the reasons why I like to cover multiple sclerosis last is it can affect all body symptoms. Okay, so you're going to do cognitive testing using something like the MoCA that we covered last semester. You're going to do a full active and passive range of motion screen, and if needed, manual muscle testing followed by goniometry. Should also test for spasticity using the modified Ashworth scale, somatosensation, light touch, sharp dull, proprioception, all of these things that we covered last semester, as well as coordination testing, which is why now that we've just covered cerebellar and talked about lots of different coordination tests, you should be able to apply this to this patient population as well. This patient population also frequently has visual deficits, so as well as vestibular deficits. So it's a good idea to pull in the vestibular and ocular exam that we learned earlier in the semester. Definitely balance deficits for lots of different reasons. You also want to look at functional mobility as well as some MS-specific outcome measures. We'll cover these MS-specific outcome measures during the group cases, so don't really have to worry about what they are right now. So in general, the treatment or management of this patient population is going to be to target their patient deficits. And as I've said multiple times, they're going to vary from person to person. So how you treat one person could be completely different with how you treat another person. Especially early on, you want to promote overall wellness and health, get an exercise program started that's going to help them maintain function, as well as recommend some support groups. And I have some links here to the National MS Society and MS Association of America. Lots of really good patient education information here, and just good information overall for patients that are going through this terrible disease process. The next 3 slides are going to divide the treatment of patients with multiple sclerosis into 3 different categories. The first category is going to be those patients with early or mild multiple sclerosis, and these are going to be patients that have minimal impairments and limitations, and they're fairly independent with all their ADLs. They're going to present with relapsing remitting multiple sclerosis, and they might have some motor symptoms present, such as weakness or spasticity, but they really don't interfere with their daily activities. As far as preventative and restorative interventions, you want to have them start a regular exercise program. This is going to help with everything. If they have any symptom at all, it's going to help, especially with fatigue. You could also recommend some community classes to help this person get out, socialize, and have a positive outlook. Hey, compensatory interventions. With this patient population, you really need to teach the person how to conserve energy with daily tasks. Okay, you also want to look for the need for adaptive or assistive devices. They might have some balance deficits, and if you use a Berg, you can determine whether or not they qualify for use of an assistive device for their safety. You may also need to suggest some environmental modifications to help their mobility throughout the day, as well as refer to other healthcare professionals as needed. Okay, second category for physical therapy treatment is going to be middle or moderate stage multiple sclerosis. Okay, this patient population is going to have the progressive course with increasing number and severity of impairments. They might have minimal to moderate activity limitations and participation restrictions. They're still Mod-I with their ADLs, but they're probably going to demonstrate some difficulty with balance, gait, and possibly have some postural instability. Again, the preventative and restorative interventions are no different from the mild early MS, general exercise program, community classes. Now, compensatory interventions, you're probably going to have to start recommending assistive devices to maintain the function of the person. They may qualify for a wheelchair. It could be a power chair or a scooter to help with community mobility. If they have any kind of motorized wheelchair, they might need a ramp at home and some environmental modifications to help them get around in their home. As always, there's patient, family, and caregiver education and training, psychological support, and referral to other healthcare professionals as needed. And finally, in a person that has late or advanced multiple sclerosis, this is going to be where you're starting to see that neurodegeneration, and you're having a progressive course with many impairments and increasing severity of the disease. They're going to have severe activity limitations and be dependent for most of their activities. They might typically be in a wheelchair or bed most of the day. They're going to need assistance with all of their ADLs. As far as preventative and restorative interventions, this is where you want to maximize upright posture and out of bed time. Even though that person is fatigued, just getting up and about is going to help You want to have them participate in their activities of daily living as much as humanly possible. Work on prevention of contractures, pressure sores, pneumonia, all the bad things that happen when you are stuck in bed and not moving around very much. As far as compensatory interventions, here family caregiver education is going to be huge. Okay, you're going to talk them through safety education, transfers, patient positioning, making sure they're turning and looking for the onset of pressure wounds. You might recommend some pressure relieving devices. Lots of different wheelchair cushions, such as a Roho cushion. It's an air cushion, can help with pressure relief. If that person is truly dependent, they might need a tilt and space chair to help with pressure relief. They may need a hospital bed or a mechanical lift. And as always, psychological support for the family and the patient, and referral to other healthcare professionals as needed. In general, patients with early, mild, and middle, moderate MS should be exercising. Okay, the general exercises guidelines for patients with MS is listed here, and this is from the Kim et al. Article. This is an article that we looked at previously when we were looking at exercise guidelines for patients post-stroke and Parkinson's. Okay, general aerobic exercise, 2 to 3 days per week. Okay, you want to also be cognizant of the fact that when a person is doing general aerobic exercise, they should be doing so in a cool environment. Remember that pseudo-exacerbation is going to be present with increased temperature. So if the person likes to swim, for example, have them swim in a relatively cooler pool. You want to start out with exercise anywhere from 10 to 30 minutes, okay, depending on the fitness of the person. They should be moderate intensity. So the RPE would be between 11 and 13 on an 20-point RPE scale, or 40 to 60% VO2 max, or heart rate reserve, or max heart rate. Okay, mode of exercise could be cycloergometry. If they're having significant difficulties with spasticity, it might be difficult for them to use a leg cycle, so they might be stuck with an arm cycle. They could do overground walking, treadmill walking, any kind of swimming is usually very good and relaxing and an easier way to cool off because pools tend to be a little bit cooler. They might also benefit from an elliptical machine. As the person gets more fit, they can progress their aerobic exercise up to 5 days per week and can actually approach up to 40 minutes. The intensity here would be anywhere from 70% VO2 max to 80% max heart rate. And in general, you want to consider. And then finally, general resistance exercise, and this is described in this paper as 2 to 3 days per week, 8 to 15 repetitions, and try and do 5 to 10. Generally, whole body exercises are going to be good with 1 to 3 sets total. So we're not worried about 1 rep max here. You just want to pick a resistance so that that person can finish between 8 and 15 repetitions of the last set comfortably. Okay, again, we're not going to overdo it with this patient population. We just want to keep them healthy. And not listed in the paper itself, but important to include in a patient's with MS exercise program would be flexibility exercises. And here specifically, you're looking for static stretching. You just want to have them stretch to the point of mild discomfort, but do not cause pain. Okay, pain is never a good thing. You want to have them hold the stretch for a total of 30 to 60 seconds with 2 to 4 repetitions. They should be stretching 5 to 7 times per week and as many as 1 to 2 times per day. Okay, special issue with regards to patients with MS. They typically will present with some sort of fatigue. Okay, there are some things to educate the patient on that might be contributing to this fatigue that could help with the management. And the first is sleep. Are they getting adequate sleep every night, at least 8 hours? Or is their sleep being disturbed by things such as urinary frequency or muscle spasms? Could be poor diet. You definitely want to follow dietary nutritional recommendations for a healthy diet, If the patient's deconditioned, they're going to tend to feel that fatigue even more. So recommend or design a nice exercise program to help improve their conditioning. If they have any movement limitations, so for example, spasticity, then that they're going to be fighting against their increased tone and might be using a lot of energy just to do their daily tasks. Patient may also be depressed, and if they have current demyelinated axons, it's going to take them more energy to do things than it ordinarily would because of the decreased speed of conduction. And as if they have a higher core body temperature, this is going to affect their fatigue, since the higher the body temperature, the slower the conduction velocity for a demyelinated neuron. And then finally, emotional stress. I mean, the stress of having this horrible disease is definitely going to contribute to fatigue. So in addition to tackling some of those pieces of patient education, you can also recommend some management with either energy conservation or activity pacing. Energy conservation would be an example of this is shown on the right-hand side of the slide, where instead of standing to chop vegetables to cook dinner, you might want to just sit down to do that. And that's going to reduce the overall energy requirements of the task, because sitting is going to be easier than standing. Okay, so you can modify your task or modify your environment. Another way to modify the task, if the chopping gets too much effort, then recommend a food processor. And activity pacing is going to be more of a throughout the day strategy, okay, where you're going to balance your activities with rest periods. You definitely want to set priorities, make sure that the person isn't doing too much or trying to tackle too much, but teach them teach them to find a comfortable rest activity ratio, where they can do a little bit of something, maybe not the full task, then take a break for a little while, and then complete the task later on.